Thanks for joining us today for this important health talk regarding the understanding colorectal cancer, prevention, screening, and early detection. And my name is Nisi George. I'm a nurse practitioner with the hematology oncology practice of Englewood. And I work with Dr. Jawar. She's also the GI oncologist. And that's also in the Berry building of the Cancer Center. We have three speakers. We have Dr. Alexander Fortgang, and also Dr. Melanie Burgos, and also Ms. Leanne Palzino. She's a colorectal survivor. And we are honored to have Dr. Alexander Fortgang, colorectal surgeon at Englewood Hospital. And excellent speakers will be sharing their experience, valuable insights, resources, and answer your questions at the end. We can give the question answers like at the end. And colorectal cancer is a common, that preventable cancer, but many are unaware of the importance of the early detection. This session will cover the risk factors, warning signs, and the best screening modes available, including the FIT and multi-threaded stool DNA test. And again, our first speaker, Dr. Alexander Fortgang, he's a colorectal surgeon, and he got his received his DO from Toro College of Osteopathic Medicine, and he was a chief resident at Hackensack Hospital, and colon and rectal surgery fellowship at Rutgers Robert Wood Johnson Medical School in New Brunswick. Now here at Englewood Hospital as the colorectal surgeon. And we welcome Dr. Alexander Fortgang to speak. And after that, the second speaker will be Dr. Melanie Burgos. She's a gastroenterologist in Englewood Cliffs, New Jersey, and affiliated with the NYU Langone Hospitals. Has been in practice for several years, and also welcoming her for this talk. And we have Ms. Melanie Palladino, a colorectal survivor, and I happen to know her. Recently, we had a patient to go to the infusion center. She was such a compassionate and person to take a time to bring him to the infusion center. I know her from that point, and she also talking about her experience as a cancer survivor. And again, welcoming Dr. Fortgang and Melanie Burgos.
Okay.
Great. Thank you. Good evening, everyone. It's a pleasure to be here. So we'll be providing a talk tonight on colorectal cancer, the importance of screening and prevention. So with that, we'll just get started. So colorectal cancer is one of the few cancers that we actually have the ability to detect early enough to prevent cancer. And so in the United States, colorectal cancer is the third most common cancer in men and women, and it is preventable. So the screening test, the gold standard screening test, which is colonoscopy, actually has the ability to be both diagnostic and therapeutic in the sense of removing precancerous growths called polyps during the initial screening test. And so when you look at the top three common cancers that affect men and women, prostate cancer, breast cancer, and colorectal cancer, colorectal cancer is the one that we actually have the ability to change the outcome of ahead of time, prior to diagnosis. And so why is screening important? Again, because we have the ability to treat therapeutically prior to it becoming an invasive cancer that requires more advanced treatments, things like chemotherapy or even surgery, because we have gastroenterologists and colorectal surgeons who can treat this and remove these polyps ahead of time. And then we can increase the frequency of screening for patients that are at risk in order to prevent them from developing cancer. And so this is just kind of a diagram of the colon. And so the colon basically starts at the end of the small intestine, which is called the ileum. There's a little valve there that lets the stool and things go in, and then the colon kind of wraps around the body. There's the right side of the colon, which includes the cecum, which is where the little appendix comes off of. That becomes the ascending colon, the transverse colon, the descending colon, finally ending at the sigmoid colon, which goes to the rectum, and then the anus. So cancer and polyps can develop in any portion of the intestine here. The good thing is colonoscopy has the ability to reach every single part of the intestine, of the large intestine, and be able to treat and remove growths before they become a bigger problem. And so screening by colonoscopy and polyp removal can prevent colon cancer. So where does colorectal cancer start? So it starts usually in something that's called a polyp, like I've mentioned, which is a benign growth by itself. It's a little abnormal growth that happens from the mucosal layer of the cell surface, and then it starts to spread as it grows. Now, depending on the genetics of the polyp, sometimes it grows faster, sometimes it grows slower, but we know that over time, eventually these polyps have the potential to become a cancer because, as you see here, as they grow larger and larger, they don't just grow upwards on the little stalk that they've created, they can actually grow, and if you look at that, the white lesion that's growing down into the pink, into the deeper layers, it can get into this area of the tissue called the submucosa, and from there it has the ability to start spreading via the lymph nodes, via the blood and other parts of the circulation, and then can even spread to the rest of the body. So when it's still at these smaller stages, which we call adenomatous polyps, before they become cancer, we can actually remove that in its entirety during a colonoscopy and remove those cell layers before they invade deeper. And so about colon polyps, most of them are harmless. Most of them are actually not adenomatous polyps. Most polyps that we find throughout the colon are actually called hyperplastic polyps, which are typically benign. But unfortunately, one of the only ways to really know, is it a benign polyp or is it something that could be precancerous, is to biopsy it, which is done during colonoscopy. And so there are different screening tests, which Dr. Burgos is going to go over as well, that all have different amounts of sensitivity and specificity for identifying risk factors for developing cancer. And then those would then be followed by a colonoscopy in order to take an actual look at the colon, what polyps are there, take biopsies, or remove them before cancer can begin. So here are just some pictures of what polyps can look like. And these are different shapes, different sizes. Some of them can look more cancerous than others, and they may not be. Some of them can look flat and small and maybe. And so that's why biopsying and removing them is really the only way to identify what they are. And so some of them can be very difficult to see. These are not the kind of things that typically show up on CAT scans or MRIs. And so, depending on the size of the polyp, it can be very difficult to identify without looking at it and taking these biopsies or removing them via colonoscopy. And so, like we keep mentioning, this is just another photo that shows we even have special cameras during colonoscopy that change the filtering of the light to help us identify, are these polyps that look more like a risk for cancer or not a risk for cancer, which helps us determine which ones need to be removed and which ones should we biopsy ahead of time. But the important thing is all of these screening tests allow us to help prevent a cancer, which is amazing when you think about all the different cancers that most people hear about, they find out after the fact. And so, like I mentioned, colonoscopy is not just a powerful screening tool, but it's actually a powerful prevention tool. And so we'll talk more, and Dr. Burgos will talk more too about the role for that, when to get screened, and what the kind of criteria are. This is just an example picture of what it looks like when you have a colonoscopy. Some people haven't seen. It's actually a camera, almost like a camera that you use to look, in the wall of your house or snaking a drain or something, but kind of just goes through the plumbing of the intestine. And on that camera, there's a little light and a little channel that goes through it, and we can actually pass instruments that are very fine through this tube that are flexible. Those instruments can come out through the tube and allow us to do little micro procedures inside the intestine to remove these polyps and to pull them out. And so even polyps that are as large as this, you see this one up here, these can be removed. We can actually, one of the tools that can come through is something called a snare, which is just a fancy lasso made of wire that goes around these and can actually cut them below their base. And then we have the ability to cauterize and remove those parts and destroy the precancerous tissue before it ever has a chance to spread. It also allows us the ability to tattoo the area, which will never show on your skin or anything like that, but inside your body, we'll be able to see it if there is a cancer that requires surgery, it allows myself, a colorectal surgeon, to actually identify the exact part of the intestine where this mass was to make a more targeted therapy in the future. And so when we talk about risk factors for colorectal cancer, so it affects men and women about equally. We are seeing that it is increased risk in the younger populations. Patients who are born around 1990 have 4 times the risk of cancer as patients who are born in the year 1950. Now, we're still trying to understand exactly why that is. A lot of it is diet and lifestyle related, but the jury's still out on the exact risk factors. But we do know that we're seeing lesions that are more advanced in younger populations, and so actually the screening guidelines are now changing as a result of this trend. Other things that increase the risk of cancer are things that increase the risk of most other cancers, things like smoking, obesity, which puts you in a chronic state of inflammation, having other types of surgery, gallbladder removal, which affects how your body breaks down fat and other things in your diet, having radiation therapy for different things, or having other types of colon diseases like Crohn's colitis or ulcerative colitis. Again, all of these things are sort of factors that increase overall inflammation. And that's, I think, really the theory behind the diet and sedentary lifestyle is it puts your body in a state of chronic inflammation. And so what are some of the symptoms that patients may experience prior to detection? Most of the time, there are no symptoms. And so that's why it's so important to do screening early and at the appropriate intervals. Because by the time there are symptoms, typically these lesions have progressed to a point where more aggressive therapy may be needed than just a colonoscopy. And so, we encourage patients, anyone who has any new symptoms, any new abdominal pain, abnormal bleeding during bowel movement, things like that, or even things like just feeling weak and tired, to go see your general practitioner and your family doctor and get some tests done and talk about it with them, because sometimes the earliest sign is really just, I feel weak, I feel tired, and they check your blood numbers and the hemoglobin may be down, you may be a little anemic, and then we have to do something to identify, well, why is that? Because sometimes these polyps can lead to a slow amount of blood loss over a long period of time. And so that can prompt us to take a look and figure out what's going on. So I know we keep talking about this, and I keep mentioning this, so should I wait until I have symptoms to get checked? And the answer is no. We know that screening is actually not just good for diagnosing patients who have already developed cancer, but even to prevent it. And so some of the other things like, I mentioned blood in the stool, any changes in your bowel habits, any increased abdominal pain, new weight loss that you weren't trying to achieve. Those are things that really can tip you off to go get checked and talk to someone. So what should I do if I don't have any symptoms? Again, get screened. And so now Dr. Burgos is going to come talk to you about some of the screening tests we have available.
Okay. Thank you, Dr. Fortgang. So I'm going to go over all the specific different tests that you can do for colon cancer screening. So, is it just the down button?
Yes.
Okay, so there are many different types of tests out there, and I'm sure that you've spoken to your primary care doctors about them. There's the stool test, there's imaging tests. First and foremost, I'm going to say that the gold standard, as Dr. Fortgang has mentioned, is always going to be a colonoscopy, the long summary, the very short summary. So there are what we call one-step screening versus two-step screening for colorectal cancer. So one-step screening involves just one test. Two-step screening means you do one test, but then a positive test will lead to another test. Ultimately, as a gastroenterologist, of course, I'm going to always tell you colonoscopy is the best test, but in reality, we know that it's never going to be what a patient really wants to do a lot of the times because, the dreaded preparation. But we will say that the best screening test is always the one at least that you do. So as mentioned, the one-step screening test, no surprise, colonoscopy. So during colonoscopy, we can look for growths, the polyps in the colon, and then also we can remove polyps. So that is the benefit of colonoscopy. So not only do we have the opportunity to look for polyps, we'll be able to remove them as well. You know, it's a very common procedure in the United States, and it is, out of all the tests, the removal of polyps offer the longest protection against developing colorectal cancer and dying from it. So the two-step screening tests, so there are stool-based tests, and these tests can detect blood. They can also detect altered DNA that are also indicative of, you know, if you have certain genetics that put you at increased risk of colorectal cancer. One of the first stool tests that can be done is called a FIT test. So it stands for fecal immunochemical test. It detects the hidden blood that's in the stool. A positive test, though, as I mentioned, a two-step test will always lead to colonoscopy will be your next step if it's positive. Now, with a FIT test, I know before there used to be offered what we call a fecal occult blood test. So that's not even an option for screening anymore. So the fecal immunochemical test, the FIT test, has lower chances of false positives, and it's actually what's preferred if you're just going to do a simple stool study to check to see if there's blood. Why? We'll also go over that a little bit later as to why it's a little bit better than the former fecal occult blood test. But in a nutshell, the FIT test will specifically test for human blood and markers that are specific to human blood that it can test. So the multi-target stool DNA test, or commonly known as Cologuard, that's also another option. So for this test, it looks for abnormal DNA associated with colon cancer and then also precancerous polyps. It's more sensitive than a FIT test, but your chance of getting a false positive may also increase with advanced age. So if your Cologuard is negative, you can repeat the test in 3 years. But once again, because it's a two-step screening test, a positive test will ultimately lead to a colonoscopy. So those who cannot do a colonoscopy, or those who do not want to do stool tests, there's other options as well. There is what we call a CT colonography and also a colon capsule. So keep in mind, both these tests do require a bowel preparation. CT colonography, let me just see if there's a good picture of it. Oh, no. Okay, there's no good picture. So once again, the CT colonography and colon capsule, if you do both of these tests, if it's positive, once again, it will ultimately still lead to a recommendation for a colonoscopy. Okay, so this is just going over the one-step, two-step tests. So as far as who should be screened, the actual ages and whatnot, so this is all dictated by the American College of Gastroenterology. So those who are average risk individuals, we'll focus on that for now because there's a lot of other instances where you may need a colonoscopy sooner than this age. Between the age of 45 and 75 years to reduce the precancerous growths and the adenomas, reduce colorectal cancer, and also reduce death from colon cancer. So once you reach 75 years old, it's not necessarily to say that you don't need a colonoscopy at all. Usually between the ages of 75 and 85, it's a discussion with your doctor as far as, you know, how good of health are you in to undergo another procedure? Have you had polyps before? Do you have anybody in your family? So all these things can be a factor into considering doing more colonoscopies after the age of 75. So as far as the first test, usually colonoscopy is always going to be recommended, or also a FIT test will be, you know, if someone doesn't want to do a procedure, FIT can also be done first. But as far as those who are willing to undergo procedure, you can also do another test called a flexible sigmoidoscopy, which is half a colonoscopy. So you are only going to see the left colon and only half of the colon at the time. so once again, they mentioned the initial test. So as far as when your next test can be done, so colonoscopy, say you have no polyps, should be done at the longest interval of 10 years. For a FIT test, it's going to be every year, assuming, of course, that it's negative. And then all these other alternative tests that I did mention, the Cologuard, if it's negative, your next Cologuard will be 3 years. The flexible sigmoidoscopy, which only looks at half of the colon, is every 5 to 10 years. The CT colonography will be every 5 years, and the colon capsule will also be every 5 years. So the CT colonography and colon capsule, I don't believe there was a slide on it, but the CT colonography and colon capsule, as I mentioned, still require bowel preparation. The CT colonography is going to be where you undergo imaging to see if you can detect polyps via imaging. And the capsule is also a pill that you swallow and takes intermittent pictures of your colon to see if we can see polyps. But once again, keep in mind with these imaging tests, if there's polyps, they can't be removed. We just know that there may be polyps. Also, there is a blood test called the Septin-9. There's no role for using that blood test for colorectal cancer screening. Some other things to keep in mind too, African Americans are diagnosed with colorectal cancer at younger ages, at a younger age compared to other ethnicities. They also do have decreased survival compared to other ethnic and racial groups, but yet still the ACG guidelines still recommend that African Americans start screening at age 45. Okay. So what we have next too, okay, so some reasons as to why you may need a colonoscopy either more frequently or maybe even at an earlier age than 45. If you have a family history of colon cancer, you do need to talk to your healthcare provider because you may also need a colonoscopy before, as I mentioned, the 45 years of age. Sometimes you also may require genetic testing if you have multiple people in your family or you've had someone who's had colon cancer at a very young age. There are multiple genetic syndromes that can make you predisposed to polyps and colon cancer. I believe Dr. Fortgang went over some of the other conditions that can also put you at risk for having colon cancer. And then getting a screening test scheduled. So how to get arranged for a colorectal screening. So if you want to undergo a colonoscopy, gastroenterology, we perform colonoscopy regularly. We do the colonoscopies, we diagnose, we treat, remove the polyps. So the colonoscopies are done by gastro. So getting screened, just once again, make sure that you speak to your healthcare providers about colorectal cancer screening, even if it's not mentioned. You should always, I think, take charge of your health and ask questions and, discuss with your doctors about whether you need a colonoscopy. Once again, colonoscopy is a very good preventative health test. So very important, don't forget to get screened. So common excuses for why some people want to avoid colonoscopy in their screenings for the colorectal cancer. I feel fine. Colon polyps and early colon cancer can develop silently without symptoms, as Dr. Fortgang, I believe, already mentioned. Waiting until symptoms occur can mean the cancer is more advanced and less likely to be curable. I'm healthy. Why get screened? So according to experts from ACG, colorectal cancer screening is for healthy people. If we find a polyp, we remove it and prevent it from becoming colorectal cancer. No one in my family had colon cancer, so don't be the first. Roughly 5 in 100 people are destined to get colorectal cancer in their lifetime, even with no family history. I have no risk factors. So the single biggest modifiable risk factor for colorectal cancer is failure to be screened. Only men get colon cancer. So colon cancer does not discriminate, so it is an equal opportunity disease. Women have the same risk as men. And with that, everyone should get their colonoscopies. I'll leave it at that. Okay. Okay. Leanne.
Hello, thank you all for coming. I want to say that first. As you all know, my name is Leanne. I'm a colorectal cancer survivor. In March of 2022, I had my colonoscopy. And I was pretty much destined to get rectal cancer, colon cancer, as I suffered with ulcerative colitis and Crohn's disease all of my adult life. And that's a phone call you don't want to get. You have cancer. So with that, I ended up having emergency surgery, and I had a temporary to possible permanent ostomy. Had that done immediately within 3 days. I went through chemotherapy and radiation, and then in April of 2023, I had my colon, my rectum, my anus, everything removed with APR surgery, and my ostomy became permanent. I was cancer-free. I'm going to stress to you, get your colonoscopy. That's the biggest thing, as the doctors had said, because I did. And I did it every 5 years. So within that 5 years, something festered to me. I was someone who thought, never, not me, never. So I said cancer-free for a year. I celebrated my lung cancer-free, and I have next to my lung, which is a test called the Signatera test. If you have colon cancer or had colon cancer, that test is very important because it shows your tumor markers. I had the surgery, my nodule removed, went through about 6 months of preventive chemo, and I stand here in front of you cancer-free. No matter what your symptom is, get your colonoscopy. It's not fun. It's not a great thing to do, but you can be detected early. Mine was stage 2B because it was caught early. And my lung was actually stage 0, but because it was mets, they call it stage 4. But the cancer itself was stage 0 because it was caught immediately. Once it was caught, within a week I had lung surgery. And here I am today, cancer-free. Thank you for your time. Thank you, doctors, for your important information.
Thank you.
Thank you.
Okay, thanks again to Dr. Alexander Fortgang and for Dr. Burgos and Ms. Leanne to share their experience and discussions about the colorectal screening. Now it's open for questions. Anybody has?
Mm-hmm.
For your invaluable information and for your testimony so much. I want you to know how the polyps moved. You said they were removed during colonoscopy. So how will they be moved?
So it depends on the size. Usually, most polyps, if you get them, your colonoscopy done within the screening age, if you do have polyps, a lot of times they're very small, less than a centimeter. Depending on the size, if they're very small, they'll be removed by biopsy, or you can also remove it with snare technique. You pretty much lasso the polyp, and you'll either cut through it or you can burn through it depending on the size. So that's usually.
Laser done at all? Laser?
So the only laser that we use is, say we take out a large polyp. The laser can be done to essentially kill the tissue around the edges to prevent further growth. So not necessarily laser it off, but you have to physically remove the polyp either by the forceps, the biopsy forceps, or, like I said, the snare, which you just lasso and cut it off.
My questions are, what about diverticulosis?
So diverticulosis is the outpouching of the colon. It's completely normal to have. It just means that the layers of your colon have a weak spot in certain areas and they form little pockets. It does not mean that you're at increased risk of colon cancer. It only puts you at increased risk for diverticulitis, and diverticular bleeding, but not colon cancer.
Okay, well, I suffered with that. A few years ago, I had to do blood transfusion.
Okay.
Last year, I was in the hospital. Prayerfully, I didn't have to get a blood transfusion. But anyways, I had a colonoscopy. When I felt everything the doctor and his assistant did because I couldn't be fully sedated because I was coughing so much. So to make a long story short, okay, I saw bleeding, so I called 911. And my 92-year-old cousin is concerned that I might not get properly diagnosed. And I want to know what's the difference between Englewood Hospital in New Jersey opposed to Sloan Kettering in New York.
So the diverticular disease is completely separate for colon cancer. So if you're asking about diverticular bleeding, once again, completely separate diagnosis. If you're saying what would they have done differently, to be honest, with any type of diverticular bleeding as to why you had a colonoscopy, you saw blood, that's an indication for a colonoscopy. You know, a lot of times we have to make sure that, one, if you're bleeding, is it something that can be treated? Also make sure it's not cancer. But with diverticular bleeding, 87% of the time, you're not going to see blood in the colon by the time you do the procedure. And it usually resolves on its own after about a few days.
Well, the doctor apologized because this doctor couldn't find why I was bleeding. But he said he saw old blood. But I'm concerned because I haven't been getting the right or correct information because I'm hearing people have been asking me, do I have what you call it, hemorrhoids? So hemorrhoids cause bleeding in the rear.
Yep.
And then I suffer with constipation that runs in the family, and I'm anemic.
I was going to say that with diverticulosis and hemorrhoids, they kind of go hand in hand. So diverticulosis, you're at risk for having that if you have a family member with it, but to prevent worsening of diverticulosis or any of its complications like diverticulitis or bleeding, avoidance of constipation is actually one of the large recommendations for it.
Okay, so do I need to take any additional tests?
For diverticulosis,
Or to see if I have the litis? Because like you said, sometimes you don't have any symptoms.
so once again, diverticulosis is completely separate from colon cancer. Diverticulitis is when you have inflammation of those sacs, and you'll usually have very painful, pain in your stomach. Or sometimes you might have bowel habit changes, but completely separate from colon cancer.
Okay, but I'm still like, I'm not convinced right now. I'm like,
I know.
feel like
I know.
I'm left in the dark somewhere. But thank you for the information.
So
Someone over there? Yeah.
in 2005, when I had my colonoscopy, they saw precancerous polyp, and it was removed. And I was told to have colonoscopy every 5 years after that, and then it became 10 years again. I went to my doctor, primary care physician last week, and she told me that I was anemic, and I was like, I'm surprised. But then I heard in the presentation that if you have your gallbladder removed, that can cause that. So can you explain how that works, how it causes cancer?
Yeah, so, the link directly from having the gallbladder removed to developing colon cancer isn't very well understood. It's a correlation that's been seen in studies, and when they look at these when they look at patients and the incidence of colorectal cancer, and they look at, well, what is common between different patient populations? Is it, and it could be anything. You can look at anything in the study. Is it the color of their hair? Is it what they like to eat? But so one thing they did find is that one common factor that had a strong association was having the gallbladder removal. Now, the theory is that having your gallbladder removed, it alters the way that your body processes the things that you eat. And so, the gallbladder is a storage organ for bile. Bile is made by the liver, and it's a fluid that the liver makes to break down fat. And that helps your body digest fat and things that have fat in it. Over time, without your gallbladder, well, the body has to accommodate. And so the bile ducts, which are the little tubes that go from the liver to the intestine, get a little larger to let more bile through. But that creates, they think, a state of a little increased inflammation that could be the risk factor for colon cancer. Now, that's why when it comes to surgery, we don't take it lightly, whether or not someone needs their gallbladder removed because they're having severe debilitating symptoms from their gallstones. But it's something that we keep in mind that once we do something like that, to just keep in the back of our head that, okay, someone who's had their gallbladder removed and is coming in with anemia or blood in their stool or things like that, that it's even more important to make sure they get their appropriate screening. Okay?
Yeah, so right now I feel like I need colonoscopy. I mean, I'm not due for another 5 years, but I think I'm going to talk to my primary care just to make sure.
Sure, I think that's a great idea.
Thank you.
You're welcome.
How are polyps different from tumors?
So polyps are growths that, there's a line where they become actually very similar. And most of what really defines the difference is what level of depth the polyp has grown into. And so in the slide that I had shown with the different layers, we call it a polyp when it's not invaded through the submucosa yet, which is one of the layers of the tissue. That's the layer where the blood vessels and the lymph vessels are. Once it gets down there, it becomes what we call an invasive tumor. And so that's kind of the defining line for when we start to change the terminology a bit.
If you have somebody, say a woman who has polyps elsewhere in the body, say they have uterine polyps, are they associated with polyps in the colon, and should they be screened before age 45?
Sure, so that's a good question. And it really depends on the type of polyps, where they are, and what the biopsies of those polyps come back as. There are certain genetic syndromes that put patients at increased risk for colon cancer, and one that specifically involves uterine cancer or endometrial cancer is called Lynch syndrome, or some of the hereditary non-polyposis syndromes can be associated with cancers of the ovaries, cancer of the uterus. And so we do increase the screening for patients who have that, but that's made on an individualized basis. Once we see a pattern, or a lot of times it'll actually be in the family history. A patient will tell us, well, 3 of my family members all had uterine cancer and 1 had colon cancer. That's kind of tells us that there may be a genetic factor at play. And in those situations, we actually can refer patients to genetic counseling to get genetic testing to look for those specific mutations so that we can know if we need to increase the rate of screening and the interval for screening. That's a good question. Thank you.
After a polyp is removed, is there anything the patient can do to avoid them from coming back?
Not particularly. As kind of mentioned in the presentation, we think that a lot of the cause of these increased risk or rate of polyp formation in colon cancer is due to what we kind of calling total body inflammation and all these different things that increase inflammatory states. So the best thing that we can say right now is doing things like avoiding smoking, avoiding excessive alcohol use, eating more of a healthy diet, increasing fiber in the diet helps for colonic health, avoiding processed foods, There is some association in theory that increased red meat or meat that has nitrites in it or a lot of preservatives, processed meats, that these all may be factors that contribute, especially because since sort of the 80s and 90s, that amount of food has become more, that type of food has become more prevalent in our everyday diet in the U.S. But we're not entirely sure. We don't have like a clear avoid this, prevent that yet. But we do think that it's all related to inflammation. You're welcome.
What's the main reason for cutting off the testing for colonoscopy after age 75 or above?
You mean what are some reasons why you could get a colonoscopy for screening purposes after 75, or
Why do they stop?
Why do they
screening at
stop?
75?
Yeah, so it's just, what's been studied through evidence-based medicine. Now, the thought is that with colonoscopies, the person who benefits from it the most is someone who also has an age expectancy post 10 years. That's usually what the thought is. So someone you expect to live for another 10 years can still undergo colonoscopy. But I know people are living longer nowadays. It's not atypical for me to have patients in their 90s, which is why the decision between the ages of 75 and 85 can be a discussion that you have with your doctor. Do you have other health conditions that would make a procedure difficult for you? Is there a benefit to it? Do you have a family history? Have you had polyps before? If you go to the age of 75 and every colonoscopy you've had 0 polyps, I would say that you're probably good at stopping at 75. But if a patient says to me, I just really want to know, then, can consider it based on that too. Other questions?
What is this new screening age to begin with?
45, with no other risk factors or
Correct.
family history. Or, and I'm not sure if it was mentioned, if you do have a family member who has a first-degree family member, so someone who's 1 degree of separation within your family who's been diagnosed with colon cancer, it's either 45 or 10 years before the age that they were diagnosed. So if they were diagnosed at 45 during their screening, then you would need to get yours at 35.
Mm-hmm.
The main difference with the other 2 options is not being able to remove the polyps to see as well, and not being able to remove the top with those 2 options that you mentioned, because certainly the whole thing with colonoscopy is the prep. So
Right. So I was going to say that with a colonoscopy and a flexible sigmoidoscopy, which is just half a colonoscopy, you do have the opportunity to take out polyps. Every other test that was mentioned, of course, there's no way to remove polyps. It's just to help you detect if you're at high risk. Maybe you do have polyps. Maybe is there risk factors for colon cancer? Do they see something on imaging? I still also recommend against flexible sigmoidoscopies because, once again, it's only half the colon. And there's also a reason why they decrease the average age of screening to begin with from 50 to 45. There were higher incidences of right side colon cancer, which is not what the flexible sigmoidoscopy, you don't look at the right colon.
Any more questions or anything like that? Thanks again, everyone presenting at the program, and everybody had a good discussion, and everybody's questions are answered. And I'm just want to thank Jennifer Yanovitz, starting program manager, population health department, who coordinated this event, and also Mikesha Shamla, program manager, Libel Center department, also part of coordinating the event. And I also want to give a big thanks to Mary Reed. She's a nurse practitioner of the surgical group, and she actually couldn't come here today, and then I was able to represent her you.